Welcome to this session, the left main, multivessel, and bifurcation. This is going to be a very fascinating session, and I'm Spencer King. I'm joined by my co-moderator, Dr. Antonio Colombo, and our panelists are Terry Lefebvre, Robert Byrne, Bon Quan-Co, and Adelaide Chieffro. And we're going to turn it over to Antonio to introduce our first speaker.
Okay, thank you very much, Spencer, and thank you, TCTAP, for this opportunity. First, we start with like a mini debate about bifurcation, provisional versus elective two stents, and Dr. Headling Smith will first give his point of view regarding provisional. Please, David.
Thank you very much, Antonio. Thank you very much to the organising committee for giving me this chance to have a debate with Xiaoliang. So the question here is DK crush the gold standard for complex distal left main stem stenosis? And the point of view I will be putting is that it isn't. So the perspectives of the European Bifurcation Club have been developed over the last 15 years or so, and have taken the philosophy that you approach bifurcations in a stepwise manner, adding layers of complexity as necessary, rather than perhaps prejudging the anatomy and deciding up front, I will use two stents. So these are two slightly different philosophies. The idea with the stepwise provisional approach is that you keep adding those layers until you stop when you have a good result. That may be not exactly when you expect, maybe earlier than you expect. And if you do need two stents, then of course you put in two stents. So for example, with the left main true bifurcation, you'd say, okay, we stent the main vessel and we do a proximal optimization technique. And then we ask ourselves, now we've done that, do we need to do more? If we need to do more, then we rewire into the side vessel, we do kissing inflation, and again, ask ourselves, do we need to do more? Stenting of the side branch follows, if necessary, followed by a kiss. And again, we ask ourselves, do we need to do more? So at each stage, it requires a little bit of judgment and decision-making. And if you can stop earlier than perhaps you thought might be necessary, that's all to the good, because the less metal you put in the left main stem, the less the risk of subsequent restenosis, as a very broad generalization. So the provisional approach is rigorous and logical. It is flexible and versatile. It does need you to think on your feet a little bit. And importantly, it offers the option to do less rather than more. As Jens Lassen loves to say, if you start with one stent, then you can always end up with two. But if you start with two stents, you can't end up with one. So why is it that DK crush has taken the plaudits and is in the guidelines for left main? Well, of course, very much to Xiaoliang Chen's group's credit, they've created a huge body of data to show that DK crush can be done with very good results. I think, of course, the immediate angiographic result is satisfying, and that may be important in some geographies more than others, where the patients actually get to see the outcomes. The pleasing nature of a immediate two-stent outcome is sometimes greater than a provisional strategy where you've done a stent and a kiss, but that doesn't mean that the medium to long-term outcomes are better. So, of course, we had a look at this in the EBC main study. The drawback of the DK crush technique really is that it's an inflexible technique. You're committed right from the start. The first thing you're doing is with the side vessel. You're committed right up front to do two stents. It is a technique which, of course, requires many steps for completion. And it is undoubtedly true in interventional cardiology that every additional procedural step offers you an original and creative way to totally mess up your case. I've said this for many years, and I'll carry on saying it, even though people are probably bored of it. There is nothing more likely to go wrong as an interventional cardiologist than a complicated bifurcation strategy undertaken as something of a novelty. It does leave, the DK crush does leave a triple layer of stent on the inner curvature. Now you may try and make this a very small mini nano crush area, but there are 3 layers. And also importantly, there is this area here where it is possible to pass your wire. Even if you're doing a DK crush, you won't necessarily have your wire always going exactly where you think it's going in the stented segment. So it is possible to have the wire outside. If we look at the 2 studies, the 2 key studies, if you like, on this, EBC main on the one hand, DK crush 5 on the other, in the DK crush trial, the pot prior to rewiring did not seem to be routinely required as far as I could read from the protocol. And of course, in that setting, there is an opportunity to pass a wire outside the stent. Of course, nearly 50% of cases had crossover to 2 stents in this study. So this was not perhaps a very surprising result, that it was difficult to analyze between the 2 studies. There was more stent thrombosis in the provisional approach, which perhaps is quite surprising in the context of left main stem stenting. And I think it's fair to draw attention to the target lesion revascularization, which really drove the primary endpoints. And although it was intended that this angiography would take place after the primary endpoint at 12 months, in fact, many patients clearly had it before. And you can see this big uptake of revascularization, which was clearly angiographically driven. So I think that has rather clouded how easy it is to interpret this trial. Having said that, in many respects, the 2 studies are complementary and had different populations. The side branch lesion length in DK crush 5 was average of 16 millimeters. That's really long, whereas in EBC main 7. Similarly, the syntax score was 31 DK crush versus 22. So these are quite different populations in some respects. The DK crush population, well, we don't see those in Europe, the US, except rarely. And of course, if something has a side vessel lesion length of 16 to 20 millimeters, well, that essentially requires a stent in its own right. So it's no surprise that a 2-stent strategy is very much de rigueur in that group. So I think there is a difference between the patients, and there's also a difference between the doctors. The Europeans have championed the provisional approach. The Chinese cardiologists have championed the DK crush. So there's probably a philosophical bias in each camp to the preferred strategy. Perhaps as a result, we could say that the Europeans would be not terribly good at doing DK crush until they really got good at it. And similarly, perhaps the Chinese cardiologists weren't quite as committed to the provisional strategy. So I think as a summary, you can use provisional or systematic techniques. Of course you can, but the provisional resulting in 2 stents is equally applicable. And if you're doing left main stem bifurcation, you should learn a technique and apply it rigorously and carefully. The actual technique itself is less important. And the point I wanted to make is, I think internationally people feel somehow obliged to do a DK crush because of what the guidelines say. So I think this is a real error, that the guidelines were specific technique. The DK crush is not really applicable to the EU population. And I think the guidelines are misleading and causing people to try things which they shouldn't really be attempting unless they've decided specifically to make that their technique of choice. No specific technique should really be promoted, be it culotte, DK crush, tap, because it's implausible really to believe that an optimally done mini culotte is clinically significantly inferior to a mini DK crush. Thank you very much.
Thank you very much, David. We go to the next speaker, different point of view. Dr. Chen will discuss about intention to treat a DK crush.
Oh, thank you, Antonio. Because David is my good friend, I don't want to hear him too much. So I slightly changed the title of my presentation to there are more similarities than difference between DK-5 and EBC main. I don't want to spend much more time on the introduction of standing technique, just study from the brief review. So far, there are only 2 randomized studies compared to stand and provisional for this left main bifurcation lesion. They are EBC main and the DK-5 study. So let's go directly a comparison between EBC main and DK-5. So let's study from sample size calculation syntax score, which was less than 32 and no limit in the EBC main and no limit in our DK-5 study according to the study protocol. Also, MI younger than 70 hours, any CTO lesion in any vessels are excluded from EBC main, but MI older than 24 hours and also for any CTO after successful recanalization were included in our DK-5 study. According to the study protocol, so in the 2-step group from EBC main included TTAP, Coulott, or DK-5 study. But in DK-5, the DK was the only 2-step technique to be allowed used. So finally, in EBC main, Coulott was used in 53%, TAP in 33%, but DK only in 5%. The primary endpoint in EBC main included all-cause death, myocardial infarction, tidal lesion, revascularization, which was totally different from the composite of cardiac death, target vessel myocardial infarction, and the TR in our DK-5 study. Both studies were designed as superiority study. So also according to the study protocol, so the expected 1-year miss rate was 25 in the 2-step group and 14% in the provisional. But in our DK-5 study, the 1-year TLF was only 7% in DK group compared to 14% in the provisional group. Here I think even I was not the steering committee member, so I guess probably because early Nordic study reported very high rate of biomarker release of the 2-step technique. So I guess probably EBC team tried to get a high rate of per-procedure myocardial infarction in the 2-step group, which could be the only reason why there was so high expected rate of 1-year miss of the 2-step group. Finally, the average syntax score was 23 in EBC main compared to 31 in DK-5. Even we stressed the requirement of yearly PCR number greater than 300 in our DK-5 study, but all the operators had higher number of PCR using provisional standing technique. As David said, the average sub-branch lesion length was 60 mm in DK-5 and 7 mm in EBC main. So briefly from the table, we can see there was significant difference in terms of the lesion complexity and the risk of the patient included in the 2 study. Also, in our DK-5 study, according to definition criteria, so the complex bifurcation lesion was seen in 31.5% in DK-5 study. It was not studied in the EBC main trial. At 1-year follow-up, so the crossover rate to stand from provisional was 22% in EBC main, almost half of the rates in our DK-5. This also indicated the very significant complex lesion in our DK-5 study. Both studies share a similar reason for touching side branches starting from ballooning, kissing, standing, or final part. Finally, Ibus use was only in 40% in both studies. At 1 year follow-up, let's focus on the 1 year mass rate after two-stent technique in EBC man, which was 17.7% compared to only 10.7%. Again, because of the different definition of 1 year mass between two studies. So I have checked my origin data to see the 1 year mass rate according to EBC main definition, which was only 12.6% after provisional from DK-5 study. Again, from table, you can see, let's go to TAR rate, which was 6.1% after provisional and 7.9% after provisional from DK-5 study. So here, I'd like to say our Chinese colleagues are very familiar with provisional rather than DK-5 technique. So even the absolute number seemed a little bit high in DK-5, but we have to remember that almost 32% of lesions are complex bifurcation in DK-5. So I think 1 year TAR rate, 7.9% from DK-5 was very similar to 6.1%. So I suggest David, next time during your presentation, please ignore the weakness of our Chinese colleagues. Also, we provide a landmark analysis of DK-5. From this figure, you can see there was no significant difference in terms of the TLF after 30 days. So it means the 1 year TLF was mainly driven by per procedure myocardial infarction after provisional stenting technique. Also, let's move to target lesion revascularization rate. Within 30 days after the procedure, there was no significant difference. But after 1 month, a very high rate, high increase of TAR after provisional stent technique. Again, from the Kaplan-Meier survival curve, you can see most of the patients who underwent TAR mostly came to hospital after 7 months. So I think the high rate of TAR after provisional was not mainly driven by increased number of routine angiography. So here also I showed the distribution of the definite and probable stent thrombosis before and after 1 month between two groups. So a few years ago, we also provided 3 years clinical follow-up. I think these figures are a little bit small to see it clearly, but from the figure you can see after 1 year, there was further expansion, separation of 2 lines between provisional and DK-5 in terms of the target lesion failure and also target lesion revascularization. Also, for the analysis of 3-year clinical outcome, we stratify all the patients according to the definition criteria. So from left to right, you can see within 3 years of follow-up, even the absolute number of 1 year TLF was higher in provisional group, but non-significant to that in DK-5 group. On the right, you can see in terms of the complex bifurcation, extreme high rate of 1 year TLF after provisional compared to DK-5 technique. So I think this is a last slide to summarize the similarity between EBC and DK-5 for simple distal left main bifurcation. I and all my colleagues and all investigators agreed the preference of provisional stenting technique, but for the complex bifurcation defined by definition criteria, two-stent technique, particularly DK-5 technique, will be the first choice. So on the right panel, you can see for distal left main bifurcation, we stratify the lesion study from the assessment of side branch lesion length. If it's greater than 10 mm, then we need to carefully assess the baseline diameter stenosis. If it was greater than 70%, so we need to provide at least 2 minor criteria. So if the lesion meets the definition of one major plus any 2 minor criteria, so the lesion could be classified by complex bifurcation lesion. Again, for complex bifurcation lesion, I prefer to suggest the use of two-stent technique, particularly DK quality technique. Thanks for your attention. Thank you.
Thank you very much, Dr. Chen. I think despite differences, I believe people can find some similarities between the two views. So, like everything, the middle most probably is where the right is. We go to the next speaker is Dr. Kang, who will discuss how to utilize Ibus to get an optimal result. Dr. Kang.
Thank you for your kind introduction. I'm Dr. Do-Young Kang from Asa Medical Center. Today I'll talk about how to optimize left main bifurcation PCI. I have nothing to disclose. The recent US guideline for coronary revascularization recommend left main disease treatment if it is significant and high anatomic complexity is shown, then CABG is recommended as class 1. And if it is not suitable for CABG, after heart team discussion, GDMT or PCI can be done. If the disease is not so significant and not so high anatomic complex, then CABG and PCI is recommended. And there is some sentence of the recommendation that in patients with stable ischemic heart disease and significant left main stenosis, CABG is recommended to improve survival as class 1. And this sentence shows that in selected patients for whom PCI can provide equivalent revascularization to that possibly the CABG, PCI is reasonable to improve survival as a 2A recommendation. The important thing is that how can we provide equivalent revascularization with CABG in left main PCI? We must think that we have to provide equivalent revascularization with CABG during our left main PCI. So we have to achieve the best result when we do the left main PCI. Furthermore, PCI optimization is really important in the left main bifurcation. When compared with OSTR shape disease, distal bifurcation disease in our main compare 10-year data, the CABG was better than PCI beyond 5 years in distal left main bifurcation disease. So if we treat in this subset, PCI optimization is really important. Then how to optimize left main bifurcation PCI? The most important thing would be selection of PCI failover patient and lesions. And also FFR or IFR, the image physiology guided selection of functionally significant lesion would be the best way to select the good candidate for PCI. And the most important thing during the PCI is Ibus guided stent optimization. Also, optimal medical therapy after PCI would be very important. Then why do we need Ibus for left main bifurcation PCI? First, it is essential tool for planning the PCI. As two lecturers discussed, the stent strategy, provisional or upfront two stent, is very important for planning PCI. And Ibus enables the accurate side branch evaluation and helps to select proper strategy. And it can measure the reference vessel size accurately, and we can select bigger stent and balloon on the vessel size safely. Furthermore, after PCI, finalizing the PCI is essential role of the Ibus. With the evaluation stent expansion rate, strut apposition, or edge problems like hematoma dissection, we can optimize our PCI and then minimize the complication. What is different with the Ibus guided PCI in complex PCI? We recently published the imaging guided PSP concept with the Ibus guided predilation, stent sizing, and post dilation. We gathered about more than 9,000 patients with a complex coronary lesions, including left main coronary artery. Primary outcome was composite of cardiac death, target vessel MI, and TVR. An imaging-guided complex PCI group showed larger stent number, longer stent length, and most importantly, larger stent diameter with a bigger final balloon size. And the primary outcome was better in IPSP group that underwent Ibus-guided stent sizing and post-dilation group. And the difference was consistent after multivariate analysis and matching method. Conclusion: with Ibus, the operator selected the largest stent balloon, and Ibus enabled safe and effective complex PCI, including left main PCI, with better clinical outcomes. Then, what would be the goal of the left main PCI under Ibus guidance? We already published the goal of the Ibus guided left main bifurcation PCI. The bigger stent area, the rule of 5, 6, 7, 8, that means circumflex minimal stent area more than 5, and LAD more than 6, and polygonal conference more than 7, and left main more than 8. If we achieve bigger than 5, 6, 7, 8 square millimeter, then 2-year, the MACE rate was less than 2%. And recently, we further gathered 277 patients underwent left main PCI with 2 stent technique under Ibus guidance with longer 5-year follow-up. And after the first published, and we did the stent expansion further, and we could achieve bigger lumen area. And in the another cutoff with a 6, 8, and 10 at circumflex LAD left main, if we get all 3 good expansion more than 6, 8, 10, then 5-year MACE rate was less than 7%. The 5-year event-free survival was 93.5%. And if we get the bigger stent area with Ibus guidance, and then clinical outcome after left main bifurcation PCI is excellent in long-term outcome. Also, with this role of Ibus, we published that Ibus guidance in the main compare registry showed better survival in 3-year follow-up. And recently, we extended the follow-up up to 10 years. And the benefit of the Ibus use was associated with the better, very long-term 10-year clinical outcomes in all-cause death and composite of death, QAV, MI, or stroke, even after the propensity score matching. Therefore, with this strong data, 2018 ESC guideline recommends Ibus should be considered to optimize treatment of unprotected left main lesions. And also, recent US guideline recommended Ibus as the 2A recommendation to be useful for procedural guidance in cases of left main or complex coronary artery stenting. So let me conclude my talk. Left main disease is a life-threatening disease, and we must use all the weapons to achieve the best result. And Ibus guidance is a key for optimizing the left main PCI. Ibus enables safe and effective PCI with larger stent and balloon, resulting in a larger final stent area. And larger stent area after left main bifurcation PCI was a key predictor of the better clinical outcomes. So this is my conclusion. Let's use Ibus guidance for the best left main PCI. Thank you for your attention.
Thank you very much, Dr. Kang. Thank you for these words of wisdom. And now let's conclude this session with a real word of wisdom by Dr. A.J. Park, who will give us some highlights upon two stents in bifurcation PCI, when and why.
Thank you, Antonio. It's right. I'd like to talk upfront two stent in bifurcation PCI. Actually, it's any bifurcation, including the limb main bifurcation, non-limb main bifurcation, when and why. Right. All right. At first, we have to realize the current status of PCI. Recent published meta-analysis, the effect of PCI, including the ischemia studies, more than almost 10,000 patients analyzed. Actually, PCI has not, any survival benefit over medical treatment. Right. So if we look at the survival benefit of revascularization compared with the medical treatment and revascularization, the main clue is large ischemic burden more than 10%. Bigger than that, large ischemic burden clear, main, just like a main and three vessel disease, multivessel disease, revascularization is better. However, real world PCI may be in almost all cases in small ischemic burden than you expected. So what is really matters, what is really problem in bifurcation PCI? I think that is small ischemic burden over side branch. So, right, look at the myocardial territory, the percent fractional myocardial mass, if you separate 10%, look at this, LAD circumflex, any diagonal 1, 2, OM branch with the circumflex, PL, and PDA branch, all side branch is less than 10% fractional myocardial mass. Look at this. Again, around only 20% of the side branches, except the circumflex, has more than 10% fractional myocardial mass. However, in circumflex has more than 90% has a 10% fractional myocardial mass. Actually, the cutoff of 10% is just used in the recent published ischemia study. Moderate severe ischemia, it's a big, large, ischemic burden. All right, that's the point. I would like to simplify bifurcation PCI with that. Large side branches, more than 2.5 millimeter. There are some data, and you want to treat them. And small side branches, actually just leave it alone. We don't need a treat for the small side branch. All right, I would like to simplify any bifurcation PCI. Right, in case of large side branches, more than 2.5 millimeters, true bifurcation disease 111011, upfront to two stent, any bifurcation disease, so the main or non-main, or whatever you use the two stent technique, DK crash just shown in Chan present data. I believe that ones is that there are many, still difference in the based on the different operator, concept, function, Ibus study, and so I believe a little bit small change, difference in the different, operator. However, if you got a clear ideas, some different two-stent technique has not pretty much, different in, influence in the long-term outcome. I believe so. And so any two-stent technique, will be okay. However, you have concern, you have consider in terms of a stent area after the stent. That depending on the vessel size, depending on how to optimize, how to expand, etc., etc. So I would like to show this some slide in the next. All right, this is the case. The main circumflex is big enough to treatment, and so this is truly distal bifurcation. The main disease is involved with the distal shock and circumflex also already. Ostium tube, very diffuse disease. So by our finding some, in some calcification. So we do, non-compliant balloon pre-dilation force, LAD and circumflex, and then circumflex stent 2.75 force, and then we do right, diploidal stent, a kind of a mini crush technique. So we prefer that one. And balloon crush, I think it's, you fill with another wire after a balloon crush, that is a TK crush technique. So the main purpose of effort to do the stent expansion to even in the TK crush, any I've guided procedure. Finally, we make a big stent area. I think that's the point, So, all right, and then we deploy the main area stent implantation and NC balloon high pressure inflation sequentially, circumflex and LAD, and final kissing balloon inflation 3.0, 3.5, high pressure. Sometimes you deploy the 20 atmosphere more than that, and then we can get the final it is like this. It's very good angiographic result for the true complex main bifurcation disease. There's another view, epicaudal, epicranial view is clear. This lumen area, look at this circumflex. Just before Dr. Kang presented data, circumflex stent area 7, POC 9 is big enough to maintain long-term outcome. Maybe the reasonable rate less than 2%, TRR rate less than 2% in the 1 year and 2 years. So just I would emphasize in terms of whatever you use the two stent, finally kissing balloon, TAR techniques, whatever you try the expansion of stent optimization and stent area. So that is cut off 5, 6, 7, 8 millimeter. If you can achieve that, the clinical outcome should be good. So red peak vessel, diagonal branches, even in the LAD diagonal branches, we deploy the two different regulating stent, and using the mini crochet can make a good angiographic outcomes and good clinical outcome too. So, right, that is another, emphasizing point. We have some data. We have a lot of, Ibus data. Only predictor for good clinical outcomes of PCI, whatever bifurcation lesion, any epicardial stenosis PCI group, stent area after PCI is very important. So whatever, circumferential stem with the portions, stent area is more than 5 millimeters square is quite enough. Stented length less than 50 millimeters, that is a kind of a feasibility of PCI. I would like to define that once. The stent areas, if you want to achieve the stent area of 5.0 millimeters square, at least the vessel diameter is more than 2.5. So I would define big vessel, more than 2.5 vessels. So reasonable straight less than 2%. That is our data. Right. So in case of small side branches, mainly main stent crossover is quite enough and don't touch small side branch compromise. Right. Look at this on the cases. LAD stent crossover, very diffuse disease, not pretty small one. However, we just do the stent crossover and angiography look, compromised. However, the flow is good. Another cases and almost same, findings. However, after the main stent crossover, side branch is totally occluded. Anyway, this is old age stable angina, old age male. They don't have any, critical symptoms. Slight increase, post CKMB elevation. Right. With that, another case is asymptomatic jailing big side branch after the main stent procedure. If you look at the jailing side branch after main vessel, look at the even angiographic high degree of percent compromised. However, more than 72% cases negative FFR. Actually, in case of the main disease, after the main stent crossover, functionally circumflex jailing is only 7%. And so in case of a small size branch, not much disease on the size branch, clinical outcomes of the bifurcation PCI clearly related the status of main branch revascularization. And second one, functionally significant side branch jailing is not common. In case of a symptomatic compromised small side branches, such as the balloon dilation with or without regulating balloon, would be quite enough. Right. We have small, but the bag of data, 2 stent is good enough. This is our, bifurcation studies. 1 or 2 stent crush technique is quite similar. Cumulative incidence is recent published, showing 10 data definition 2 study. 2 stent is better than the provisional stent. I would, in the DK crush is a top of, effort to expand the stent optimization to get the big, stent area. The reason why it had a little bit good, clinical outcomes. A higher main branch lesion rate in routine kissing balloon inflation compared to the conservativity with alone, proximal main lesion rate is high, distal main lesion is high, side branch is relatively low. However, routine kissing balloon inflation not usually good for the bifurcation intervention. High target vessel failure, aggressive treatment of side branch will be higher target vessel failure at 3 years. So I'll draft a summary. If the side branch is big, more than 5 millimeters, true bifurcation, upfront to 2 stent, any 2 stents are recommended for any bifurcation. Large side branch disease is the worst of treatment. We can avoid the risk of side branch closure. Clinical outcome of 2 stents are really good, compared with the optional single stent technique. Thank you for your attention.
Thank you very much, Jay. I think we have some time for discussion. We got a lot of points to discuss. Let me open to whoever want to start first. I have myself some questions, but I would like to leave to the other speaker the first step.
Antonio, I don't want to take too much of the questions, but it's amazing to me to see such fantastic experts using different methods and coming up with good solutions. It occurs to me that some operators are very high volume operators and become super expert at even complex procedures. But guidelines sort of give the recommendation for everyone, high volume, not so high volume. And then I wonder, Xiaoling, when you talk about a DK crush, which is primarily what's done at my institution, and there are many steps, and so I'm attracted to this idea of keeping it simple, maybe for someone who is not doing a great deal of the time. So what's your impression of people of the guidelines, which seem to indicate that everyone should use a 2-stent DK crush techniques for a lot of these lesions, if the operator is not doing it many times every month?
But I totally agree with you, Spencer. In the general population of the average interventionist, I would say that it's better to do a mediocre job with 1 stent than with 2 stents. Because when you implant 2 stents, you really take more responsibility. But one point I would like to make regarding SJ and Dr. Kang, I totally agree. The fact that the bigger the better, and the side branch, whatever, should be more than 7, if you can even reach 8. But in real life, the dirt has to go somewhere. If you don't take the plaque out, if you push it from the circ to the LED or push it from the LED into the circ, it's not always possible to get an optimal result. I mean, unless you're willing to break some vessels. But, we used to have optimal result when we did DCA. but then we weight the patient before and after the procedure. But if you don't weight the patient and you show that the lesion is gone, it's not so easy to get an optimal result. Even with plaque modifying technique, we have to acknowledge that we do not have any debulking device. We have only plaque modifying technique.
Right.
I think, Antonio, I think it's a very important point. And we know that when we are treating left main, there is more calcification than in other vessels because these patients are older than the mid-age of the patient who have bifurcation of the LED or the distal right. So there is more calcification. So we have to deal with that. And I think, as you said, plaque modification is very useful. And I think that shockwave is a very good technology in this field because you avoid or decrease the risk of coronary shifting when we treat one of the branch and then treat the other one. So, of course, today we are not using DCA in Europe or maybe a few centers, but they are still using it in Japan. So I think it's a very important point, as you said. The other question is Ibus guidance, and I think it's not simple because we know that in the left main you have negative remodeling or positive remodeling. So if you have a large positive remodeling, you will go to a very large stent and maybe too large. And if you have negative remodeling guided by Ibus, you may use a stent which is too small. So I wonder if Dr. Khan can explain how they deal with this problem of remodeling of the left main and select the right stent for each patient.
Thank you for your excellent question. That's a problem during the Ibus guidance. So the number of the 5, 6, 8 is not the uniform number. The important thing is to achieve bigger lumen area in safe range. And Ibus guides with the reference vessel diameter and the safe guide for the stent optimization. If there is an under expansion, then the stent area would be smaller than other situation. And the most important thing, as Dr. Colombo suggested, is to know the vessel before PCI that the outcome would be good or not. I think that we must research and make some criteria for successful PCI to find the patient with the successful PCI result before going to the PCI. If we can select the patient that will achieve bigger lumen area, better clinical outcome before PCI, then we can select the patient and can perform the best PCI. And also, if we can select the patient that would not be good for the left main PCI with the severe calcification, and then that the patient would not be good candidate for the PCI because we have very excellent weapon, cabbage, and then the patient would be the best candidate for the cabbage. So.
All right, I want to just comment for. If you look at the different drug-eluting stent has a different cutoff values in terms of the stent area to reduce the wisdom resistance rate. That is relatively old data. First and second generation drug-eluting stent, obviously stent area is more than 5.5 millimeter square something. However, recent, secondary drug-eluting stent, any drug-eluting stent, the cutoff value is around the 5 millimeter square. Look at this. Stent area is 5 millimeter square. Actually, the vessel, diameter is 2.5 something. We're gonna use the 2.5 stent and fully expansion. We can expand it that one. That is stent, area is 5 millimeter, exactly 5 millimeter square. So totally, I agree Antonio's suggestion. In case of calcific lesions, we have to pre-modified stent, absolutely, cutting or some debulking with revelation, etc. However, the stent area by Ibus is depending on the vessel size, actually, in almost all cases. So what I'm, presenting is big vessels, small vessels, the cutoff value 2.5. We're gonna do less than 2.5. We're gonna expect less than 5 millimeter scale, stent areas. However, in small vessels, sometimes the 4 millimeter scale is the maximum, stent expansion. However, we can expect a good clinical outcome for those vessels. And so what I'm saying is, the clinical data, ischemia studies, many, recent randomized studies, PCI is not a standard for the small vessel disease. So in any bifurcation, in any disease, I think small vessel, just leave it alone. That is the bifurcation disease, right? Small bifurcation disease, small side branching, you want to open up, drug-eluting balloon for that. In terms of a clinical endpoint, I think is we have to change the conceptually, right? Personally, I think so.
But I agree with you in general, but SJ, there are some lesions where you have nodular calcium that even with lithotripsy is difficult to get a good result. Mm-hmm. There are some lesions where it's fibrotic that is damn difficult to get a good stent expansion because lithotripsy we know doesn't work or tableto doesn't work. So, I mean, in general, yes, but we have to accept that even with current technology, optimal stent area is not always possible.
Yes. Real world, really, I agree with that one. However, the reason why I really finally we're going to optimal stent area is related with a good clinical outcome. The meaning is vessel size would be related to clinical outcome. So I would say small vessels, many, lots of clinical data. Actually, we don't need a touch for that one. So in terms of a bifurcation PCI, we have to totally, change the concept in terms of for the small vessels, the balloons, stent. I think it's a clinical endpoint wise, we don't need that one. All right, that's my point.
And maybe to finish for next year, a very interesting emerging field is the role of a drug-coated balloon on side branches. Maybe not for typically the left main, but for many other side branches, I think the drug-coating balloon is getting a good position. And so back to provisional.
And Antonio, the other thing I would like to see next year or some year in the future is a better way to know which patients will not get optimal outcome. If we had that in my institution, I could know who to refer for surgery. But since the technology has become so good, now very few patients are going for surgery. So I just need to know who's going to have who is not going to achieve a good outcome, both from the cross-sectional area and as Dr. Ban Quan Ku knows very well, the physiology of the flow. I'd like to see who can predict what will be the bad outcome.
Spencer, most probably advanced multi-slice CT will tell us. We don't need to do any attempt PCI, nothing. We will know from the good quality multi-slice CT will tell us time ahead.
Yeah, maybe so. All right, maybe we should move to the next session, Antonio.
And we have the pleasure to have an interventionist, a cardiology, and the cardiac surgeon. And I really look forward to hear from the cardiac surgeon because cardiac surgery is always on our side because we have to look at the patient, not at our profession. Okay, the first speak, this session is about guidelines and 2 ways to look at the guidelines. One is Dr. Bangalore and the other is Dr. Gaudino. from Cornell. So let's start with Dr. Bangalore, and then we go to the cardiac surgeon.
Thank you very much, and thanks for having me on. And it's been a wonderful discussion so far. So I've been asked to kind of give a interventional cardiologist perspective on left main and multivessel disease from what we did on the guidelines. So these are my disclosures. I'm on the guideline writing committees. I worked very closely with Mario and many of the surgeons for many of these recommendations. But I think what I want to do in the next few minutes is to basically focus on stable coronary artery disease, because I think that's where the controversy is in terms of guideline recommendation and what we recommended. So in terms of management of stable coronary artery disease, there are multiple different options. One is optimal medical therapy. Optimal medical therapy targets culprit lesions, severe stenosis, but also it targets the non-culprit lesions, which many a times vastly outnumber the culprit lesions. So it's 10 to 100-fold higher non-culprit lesions than the culprit lesions. Then you have coronary artery bypass surgery, which targets a culprit or severe lesions, but it also bypasses the first 50 millimeter part of the coronary tree, or the first 2/3 of the coronary tree. So it does provide protection against any plaque rupture in that particular segment. And then we have PCI, which mainly targets culprit lesion. So using this framework, let's look at potential reasons for revascularization in stable coronary artery disease. So one of the overwhelming goals, I mean, if we go back to the 2012 guidelines, the 2012 ACC/AHA revascularization guidelines basically focused on a recommendation for revascularization to improve survival, and also recommendations to make the patients feel quality of life better, angina-free. So the guidelines was purely focused on making patients live longer or feeling better. And I think that will be kind of the kind of what I will talk about in terms of trying to see if we can improve survival. So the potential reasons to revascularize are to potentially improve survival. And are there data to support that revascularization in stable coronary artery disease can improve survival? If you look at the trials, and I think this is very important because there is a lot of confusion on social media and everywhere else, because there are trials like this back in the 80s, which compared bypass surgery to no bypass surgery with hardly any medical therapy. And clearly there was significant benefit of bypass surgery at reducing mortality. So here you see meta-analysis by Salim Youssef looking at no cabbage versus cabbage, significant mortality benefit at 5 years. And at 10 years, you can start to see that the curves start to converge, but this is still statistically significant. Absolute difference is smaller. But this is in the era of no medical therapy. And these were the other studies which were included in this particular meta-analysis. So no medical therapy, cabbage definitely reduces mortality when compared to no cabbage in these group of patients. But if we move forward to the modern era where there is more medical therapy, one consistent message, and again, what I want to focus here is not composite endpoints. And I think the other lingering confusion when we start debating about all of these is using composite endpoints. But if you look at mortality as an endpoint, one consistent message across all of the trials, whether it's COURAGE trial, BARI-2D trial, and even the FAME2 trial, which is largely used as the positive for PCI, the consistent message is there has been no difference in death between revascularization and medical therapy. In the trials that we ran, the ischemia and ischemia CKD, again, the point I want to make here is there are no crossing curves for mortality. There are two curves superimposed, no difference in mortality between invasive and conservative strategy in the ischemia trial and also in the ischemia CKD trial. We did a meta-analysis of randomized trials, 14 randomized trials, 15,000 patients, and we only restricted trials where there was some amount of medical therapy. And if you use these trials where there was some medical therapy, you see that again, revascularization compared to medical therapy alone, no significant difference in death up to 4.5 years of follow-up with close to 65,000 patient years of sample size. Of course, there are other meta-analysis, and I think this is again important to separate out. Navarese published this meta-analysis in European Heart Journal, where pretty much all trials were used without breaking down into whether they were older trials with no medical therapy, etc. So if you use all the trials, there is a trend towards a 21% decrease in cardiac mortality, but it's important to recognize that 12 of the studies were conducted more than 10 years ago. So the applicability of this analysis to modern day practice is therefore questionable. But even if you consider this analysis, you see that the absolute reduction in cardiac mortality is 0.2% per year. I think this is also important when we consent our patients, because even if you think that there is a mortality benefit, the benefit is small in terms of absolute reduction per year. So if you go back to a drawing board, potential reason for revascularization to improve survival, most studies have not shown an improvement in survival compared to medical therapy. There may be, if you include older studies, there may be a small reduction, 0.2% per year in cardiac death. But if you go back to the 2012 guidelines, they listed a set of subgroups where revascularization can provide survival benefit, and these included left main disease, patients with LV systolic dysfunction, 3-vessel disease, proximal LAD disease, and extensive ischemia. So if you look at patients with left main disease, the data we have, again, is from back in the day trials, CABG versus no CABG. And in this left main subgroup, which was based off of 150 patients in those randomized trials, there was significant benefit of CABG when compared to no CABG for extension of survival. And you see this extension of survival is close to the order of 2 years. And so this is the data we have for left main. And since then, all trials have excluded patients with left main disease. And as such, revascularization is the standard of care for patients who have significant left main disease, and this can potentially improve survival. If you look at patients with the LV systolic dysfunction, this was tested in the STITCH trial, comparing CABG versus medical therapy. And again, in patients who have LV systolic dysfunction, significant mortality benefit of bypass surgery compared to medical therapy alone at 10 years with a number needed to treat of only 14. Now, the more controversy is surrounding the area of triple vessel disease. There is this notion that, we, as a guideline committee, we downgraded the recommendation for CABG, but I want to point out the data we weighed were a number of factors. So here, if you look at patients with triple vessel disease, in the 1980s, CABG versus no CABG, when there was no medical therapy, in patients with triple vessel disease, there was a mortality benefit of CABG, extension of survival of 6 months in this subgroup of patients. But let's fast forward to BARI-2D. BARI-2D enrolled patients with diabetes, and in the CABG stratum of the BARI-2D trial, patients enrolled there were largely multivessel, triple vessel disease patients. And if you compare now the same CABG to medical therapy, there is actually no mortality difference between revascularization and medical therapy. I mean, I'm not using PCI here. We are still using CABG in the CABG stratum of the BARI-2D. And again, if you purely look at mortality as an endpoint, back in the day trials, mortality benefit with modern medical therapy, there is less mortality benefit, even with CABG when compared to medical therapy alone. And if you look at ischemia trial in patients stratified based on 1, 2, or 3 vessel disease, we did not see a significant interaction. There was no significant difference between invasive and conservative strategy, regardless of extent of coronary artery disease. The same was also true if you look at patients with proximal LAD disease. This is ischemia trial looking at patients with and without proximal LAD disease. Again, no significant interaction, no significant difference in mortality between an invasive and a conservative strategy. And this is also true for patients with based on the amount of ischemia. So whether patients had moderate ischemia or severe ischemia did not really matter. There was not significant heterogeneity of treatment effect based on invasive or conservative strategy. There is also this lingering confusion whether some of the ischemia results apply to CABG. But I must point out that if you look at revascularization versus medical therapy trials, there were 500 patients, over 500 patients who underwent CABG and ischemia, and that actually far exceeds any of the individual trials that I showed, which were done in the 80s comparing CABG versus no CABG. So in fact, more patients in ischemia underwent CABG than any trial of revascularization versus medical therapy. And I also showed that CABG does reduce mortality, but this is all based on trials done a couple of decades ago when there was hardly any medical therapy. And I'll show some data that PCI also reduces mortality, and it's not just CABG alone. What are the other reasons to consider revascularization to prevent other cardiovascular events? And in ischemia trial, what we showed was invasive strategy in red compared to conservative strategy increased procedural MI, but there was a significant reduction in spontaneous MI. And you can see these curves, and these curves continue to diverge, suggesting a significant benefit at 33% reduction in spontaneous MI with the invasive strategy when compared to conservative strategy. And what we also, if you look at the meta-analysis of all randomized trials, we see that revascularization reduces spontaneous MI, reduces unstable angina at the expense of increase in procedural MI. And of course, there is controversy about the clinical prognostic value of procedural MI in these group of patients. What we also showed in ischemia was that type 1 MI, if you consider CON in blue, was reduced both by PCI and CABG. So there is always this lingering debate whether PCI can reduce MI. In ischemia, we clearly showed the spontaneous MI, and type 1 MI is reduced by both PCI and CABG. So if you go back to a drawing board, potential reasons to revascularize in stable coronary artery disease to prevent other cardiovascular events, which includes reduction in spontaneous MI and unstable angina. And of course, finally, to improve quality of life, what we showed in ischemia, if you look at the curves in red, which is invasive, to blue, there is a sustained and durable benefit of improving angina-related quality of life. And this is up to 4 years of follow-up. And of course, this benefit is mainly in patients who are symptomatic. If your patient is not symptomatic, you're not going to make an asymptomatic patients feel better. So I want to show some conclusion, but also go back to the guidelines. So the 2012 guidelines suggested that all these subgroup of patients would benefit from an improved survival with revascularization. For left main disease, there is data, but of course, this is based on 150 patients back in the day. LV systolic dysfunction, clear benefit from the Stitches trial. But I must point out that if you look at 3-vessel disease, proximity, and extensive ischemia, if you look at all of the contemporary trials, no robust benefit for improving survival. And I must point out, I mean, the confusion seems to be that, we are talking about survival. We're not saying don't revascularize for triple vessel disease. There are other benefits, reduction in spontaneous MI. If the patients are symptomatic, they'll feel better. So other reasons to revascularize is durable benefit at reducing angina, reducing spontaneous MI, patient preference matters. And this is one of the reasons in our guidelines, patient preference and heart team approach is critically important and central for all of this. So revascularization to improve survival in left main disease, we gave CABG a class 1 recommendation. And in patients where the PCI can provide equivalent revascularization to that of CABG, PCI can be considered in that group of patients. What about patients with multivessel disease with the sole intent of improving survival? It's now a class 2B, the CABG, to improve survival in patients with normal ejection fraction. I think this is what is driving the controversy, but we are only referring to improving survival and not for other endpoints. I know in the interest of time, I will end here, but if you look at patients with LV systolic dysfunction, revascularization is class 1, especially with CABG. You can consider PCI in patients who are appropriate candidates for that. But if you have proxial AD and single or double vessel disease not involving proxial AD, there isn't really robust benefit that revascularization will improve survival. Maybe let me stop there, and thank you for your attention.
Okay, Antonio, I think we should work
Thank you.
on to
Let's
the next, the opposing view here.
Thank you for the invitation. It's always nice to be the only surgeon on the panel, even though the remote approach makes things easier. I will not actually debate Sripal. Most of the time we agree. And we agree even in this situation. Sripal has beautifully illustrated the reason behind the recommendation comparing revascularization with medical therapy, and I fully agree with everything he has said so far. So in my presentation, I will focus a little bit more on the comparison between the two revascularization strategy when revascularization is indicated. So PCI versus CABG. I do not have any conflict of interest to disclose. So let's, you know all those data, so I will be fast. I will just try to provide a surgeon perspective that I think most of you would share. If we go back to the origin, to the syntax trial, which we have to remind ourselves was an all-comers trial, where even patients with complex coronary artery disease were included. And we look at the comparison of the outcome between the two revascularization modality. Well, we found a clear reduction of repeat revascularization with the surgery. We found some reduction that is statistically significant, but in terms of absolute difference is smaller in MI. And then in the composite outcome that include MI and repeat revascularization, but no difference in survival between PCI and CABG. And when the results of syntax were extended to 10 years, there was, again, no difference in survival, in all-cause mortality between PCI and CABG, even though patient with pre-vessel disease seems to benefit from surgery at subgroup analysis. And also it's important to note that when the follow-up was extended to the maximum possible follow-up, which was a mean of 11 years, the small difference in favor of surgery, even in terms of mortality, becomes statistically significant. However, like Sripal said, it's not only survival, it is quality of life. It's probably even more quality of life than survival from the patient perspective. And when we look at the quality of life data from syntax, we see that the two revascularization strategy are both highly effective in relieving angina, but clearly with surgery there is a higher upfront price to pay, significantly higher period of physical limitation, which is due to the recovery from surgery. In this individual patient data meta-analysis of trial 11,000 patients, surgery was associated with a survival benefit 5 years, but we needed to acknowledge that most of the trial pooled here were relatively old and do not represent current practice, in particular in the PCI arm, and the benefit seems even more evident in patients with diabetes. Sripal and I have looked at the association between syntax score and the relative outcome of PCI versus CABG trial, and we found no association between a syntax score tertile and the relative outcome of PCI and CABG in the published trial. So while we believe that the complexity of the coronary lesion matter, and it matters more for PCI than for CABG, the syntax score per se should probably not be used to guide clinical decision making. When it comes to left main, well, the data are pretty consistent with what I've just showed you. In novel, at 5 years, no difference in survival, statistically significant reduction of MI and repeat revascularization in favor of surgery. MI did exclude perioperative MI. No difference in stroke, and statistically significant difference in a MACE outcome that included repeat revascularization. And in Excel, well, Excel was an outlier because there was a survival difference in favor of surgery at 5 years. but there was no difference in MI, even though the curves were crossing and the results were highly dependent on the definition of MI used. The known large reduction in repeat revascularization with surgery, and we need to acknowledge that repeat revascularization is by far the least important outcome of revascularization trial, and no difference in stroke. So when the Excel investigator used a primary composite outcome that did not include the repeat revascularization, there was no difference between the two treatment modalities. When repeat revascularization was included, surgery did better. I think the Excel investigator with this time segmented analysis really beautifully illustrated the difference in time horizon between the two modalities. Again, with surgery, you pay a higher upfront risk, and then you have a long-term benefit for those patients who are fit enough to live to see the benefit of surgery. And again, when we look at the quality of life data from Excel, they are consistent with what we have seen in syntax. Similar effect of PCI and CABG in treating angina, but clearly a significantly higher price to pay periprocedurally for surgery. We all know Sabatine meta-analysis, but again, it confirmed the result, no difference in survival, except in the long term where surgery is better, a reduction in MI and in repeat revascularization in favor of surgery, with the MI outcome highly dependent on the definition used. So again, I think we are just comparing two different interventions here, and Sripal has already defined that PCI treat only the flow-limiting lesion, but it's much less invasive. You have a faster recovery. With surgery, you have better protection against progression of the disease, but you pay a higher early price. So my conclusion in patients with multivessel disease and left main is that amenable to both treatment, surgery has consistently been associated with similar mortality and reduced risk of MI or repeat revascularization at the price of an increased periprocedural risk and longer recovery. It is important that we know that the absolute difference between the two interventions are small, with the exception for repeat revascularization, which again is the least important outcome, and become evident in the long-term follow-up. And the difference in favor of surgery is particularly evident among diabetics and patients with complex disease. PCI and CABG are different interventions. They are performed in different patients with different aims. With surgery, you have a higher procedural risk, but then better clinical outcome in the long term. PCI assure outcomes that are comparable to surgery in the first years, with lower invasiveness. The two interventions are complementary, not antagonist. And with this, I thank you for your attention.
Thank you very much. I think we have now a few minutes available for discussion. Please, the field is very large, of course, but let's give some word of wisdom to the audience.
I'd like the panel members to chime in, but I want to ask Dr. Bangalore. I'd certainly sympathize with the people who work on these guidelines. I've done this in the past, and it's a very difficult job. But it occurs to me that the gulf between the guidelines and the practice is enormous. That when the guidelines, of course, are based on all these trials, and yet what we do in practice is I look at cases that are very difficult cases that are being done, and the people are not having horrible symptoms that are just forcing the procedure. People are having revascularization because they believe that, and their physicians believe that they are helping them live longer, regardless of what the guidelines, what the evidence from trial shows. And another thing that bothers me is that the guidelines are based on trials that have patients in them that have been screened already, and we decide that the patients are okay to be in the trial. That is, some doctors have decided that the patient, there is equipoise, and in the patients where there's not equipoise, where we have a strong bias toward revascularization or not revascularization, those patients are excluded. So I still, I think the guidelines are wonderful, they're helpful, as long as we remember their guidelines, but they may not resemble the patient in front of us enough to help us decide what to do. And I'm afraid that the news reporting about guidelines may be more troublesome than the guidelines themselves. What's your take?
No, absolutely. I absolutely agree with all the points you have said. I mean, guidelines are guidelines. They're not the rule of the land. So I think that's the critical, important message that everybody has to take into consideration. I mean, it's based on the best available data, which is applicable to a select group of patients involved in randomized trials. So at the end of the day, it's, and I think, one of the things that we are trying to make it is patient-centric and have a heart team as the clear central piece of all of this. I mean, we may say, okay, this revascularization is best for this patient, but that particular patient, when we have that patient in front of us, may have different viewpoints about upfront risk versus late benefit. And I think we need to listen to those patients. But I completely agree with you. And I think the key message is guidelines are guidelines. It's not the rule of the land.
I mean, may I put some question and also, give something. So I agree. Clearly, we have to take care about the guidelines within the country that actually we are operating, and that's very important. Limitation, because this is from randomized clinical trial mostly, and reality, we know very well that most of the patients are excluded from this randomized clinical trial. But however, it was introduced patient-centric. So do we think that indeed, also in designing randomized clinical trial, we should put in the center also the patient point of view? Because clearly to a patient, if they die or they survive, that's important, but mostly patients ask to have a better quality of life. So what about this point? Patient-centric randomized clinical trial in order of outcomes. What do you think? This is going to be the future? We have to redesign clinical trial to take care of that?
Yeah, maybe I can quickly weigh in. I mean, nowadays, more and more, we are also, at least for NIH trials, we need patient input, at least in a few of the trials. So I think we're moving towards that phase. But it's easier said than done. But I completely agree with you that at least on a clinical grounds, patients are central piece, and patient preference does matter.
Yeah,
and I can add to that.
Emphasis on patient-centric interests me, because I thought always that the patient was centered, and I didn't think that was a new discovery, that the patient should be considered. But what about, let's ask, we don't have a lot of time, Dr. Byrne, what's your take on the guidelines?
Yeah, certainly agree with a lot of what has been said already, and it's obvious that these are guidelines, and for the guidance of the wise and the obedience of the not so wise, I suppose. Alaida's point is well made in terms of involving patients in trial design. Of course, the other area that we need to involve them is in terms of the guideline writing. And I know that many of the guideline writing task forces have started to incorporate patients with the disease who can represent their point of opinion. And it's not easy because, if you've got a large task force with 20 plus cardiologists and one patient or two patients, it's difficult. But I think we need to work on ways of engaging patients in writing the guidelines more. The one thing when we do engage with them is that we hear what we've talked about today, is that the quality of life is critically important for them. And we do need to do a better job of capturing quality of life in clinical trials, because we don't do that systematically as well as we should.
Okay, all right. We have a lot of data, including the syntax. We have some 2016 something we published, the patient level meta-analysis, the syntax, pre-combat, and past. Among that data, those that we've learned clearly the soft endpoint, spontaneous MI and DPT revascularization, it will be higher in PCI arm. And however, mortality concern, if we look at 5-year data, 10-year data, syntax, pre-combat, even novel study, for the main, absolutely same, no difference at all. The meaning is spontaneous MI and DPT revascularization would be a soft endpoint. Those soft endpoint could not translate to the hard endpoint mortality concern. If you look at the separate with soft endpoint and the hard endpoint mortality concern. So we published the data issue about the complete revascularization and incomplete revascularization. The patient group who had a remain with the multivessel and high syntax score. In case of a complete revascularized PCI, it's absolutely same with the conventional, bypass surgery in terms of, base rate. This is the data from our patient level meta-analysis. The meaning is, ischemia study support that one. We're gonna, can make an equipoise between the PCI versus the surgery, complete, even in the incomplete, complete, PCI revascularization for that. However, those soft endpoint could not translate it to the hard endpoint mortality. The reason why ischemia study clearly demonstrate invasive and conservative had no difference at all. Right, and so in the study, we clearly see that some difference. However, mortality is exactly the same. The ischemia study supported just leave it alone, even in spontaneous MI and repeat revascularization is really soft endpoint at the clinical follow-up period. That is my interpretation. And so, all right, we are on the very changing period in terms of PCI and optimal medical treatment. And so we've learned a lot from the last year's ACCH guideline. Right.
Well, from my point of view, I just want to thank everyone for participating. This TCT Asia Pacific once again has become a landmark in expanding our knowledge and pointing out how similar we are even in our differences. So thank you all for participating. Antonio, any final words?
No, I think, it's not so easy now in this time of perfection to do better, but every time we add a small step. So I think we are refining bifurcation and we are refining best treatment for our patient. And I hope next year we will be refining even more. Bye-bye.